Here we go with another topic. For some reason I got the colorectal stuff, so today we've got a very brief overview of diverticulitis. And again, I'm very surprised to read how superficial SCORE is. When we have the review session at 8:30, I kind of went through the colon questions, which are a little bit more, they seem to be focused on volvulus, carcinoid, and ulcerative colitis. That seems to be the focus of the questions. I don't know if that transponds over to the ABSCITE questions or anything, but we'll go through that later. So here's just a quick diverticulitis talk, okay? This seems crazy now. Okay. So just a little anatomy picture, and it shows that a diverticulum of the colon is actually a false diverticulum because you've only got protrusion of part of the walls. It goes through the circular muscles. And in some of my reading, one of the questions that popped up a couple of times, and you're like, who really cares, is that there are 3 tinea, and one of them is on the mesentery, kind of buried under the mesentery, and the other 2 are free. So if that pops up, there's 2 free and 1 in the mesentery. I don't know why they cared, but it came up twice when I was going through this. But the incidence of diverticulitis increases with age. Of course, they're most common in the sigmoid, where the stool is more solid, and peristalsis is kind of a more firmer contraction. And in those patients that have diverticula, about 10 to 20% can expect to have an episode of diverticulitis in their lifetimes. By definition, diverticulitis is a perforation. And so it may be a microperforation that's walled off and contained in a phlegmon, or it could be a free perforation with free perforation of pus or feces. And the average age for an admission for diverticulitis is about 63. This is just an endoscopy picture that doesn't project so well, but looking at them from the inside, it's just kind of the inside of a blister, you can think of it. All right. So uncomplicated diverticulitis are the patients that we don't see on surgery. These get admitted to medicine or family practice, or if they're admitted at all. And most of them can be treated as an outpatient. So symptoms are just like everyone would expect: left lower quadrant pain, perhaps some low-grade fever, irregular bowel movements, can be constipation or diarrhea or a combination of both of those, and commonly have urinary symptoms where the inflamed sigmoid is somewhere contacting the bladder, and so the bladder is irritated. So there may be some dysuria. But kind of the good news on these: self-limited, confined inflammatory process in a phlegmon, and we don't see these. And so these are going to be seen in the emergency room and can be treated as an outpatient. But of course, you've got to have the optimal patient. And by compliance, we mean somebody's going to go purchase the antibiotics and take them themselves. That their pain is tolerable. Perhaps they need some narcotics to go home with, which is going to what? Increase your constipation. And a low-grade fever, which they say is less than 102. But I mean, an adult with a fever of 101, to me, probably is going to come in the hospital. And somebody that can hydrate themselves, can take PO, and not too sick to start with comorbidities. But that 102 fever sounds a little high for me. Diagnosis has to be made by a CT. Certainly there are people that just get antibiotics thrown at them with a complaint of left lower quadrant pain that may not be of any significance. But you got to have the CT to diagnosis. And the treatment recommendations are actually that the first dose of IV antibiotics are given, in the emergency room, a dose of IV antibiotics. And then 10 days, I didn't write the generic names, but Cipro and Flagyl, 7 to 10 days, but closer to 10. If for some reason you can't use Flagyl, clindamycin is acceptable. And the 2 big organisms you're covering are E. coli and all the Bacteroides species. Patient is encouraged to take a liquid diet for a couple of days, which they're probably going to do on their own because they're not feeling well. They're going to limit their intake. And if they're not improving by 24 and certainly 48 hours, you've got to think something else is going on. So you're thinking, at least we have an abscess, if not something worse. So here are the imaging, just 2 pictures of diverticulitis. Should involve the sigmoid colon, and they recommend oral contrast, so you get it kind of down below. So what you see is the thickened wall. These are the diverticula with a little bubble of air in them. These aren't necessarily free air bubbles, but these bubbles are in the diverticula. Mucosa is kind of swollen into the lumen. Here's one that's a little bit higher, but still rectal contrast, which, we're going to be consulting on these patients after this is done, so we probably are not going to have the rectal contrast. But findings will be localized thickening of the wall, and it's usually a fairly long segment, and that's something to kind of keep in consideration. A cancer is usually not going to be a long segment like this. It'll be a very more discrete lesion. Inflammation in the pericolic fat, you don't really see it so much. There's a little bit here, a little bit over here, not a lot of fat right here on either side, a little bit over here. Extraluminal air, and maybe a fluid collection. Antibiotic regimens. These are for people, what they suggest are the ones that have to come in the hospital for whatever reason. They're not tolerating PO, they've got too much fever, too sick, too many more comorbidities, or immunosuppressed for whatever reason. Zosyn's always good for anything in the abdomen, usually with flagell, doesn't much matter without. Third generation cephalosporin, so that's like Rocephin, which is a Q24-hour dose, which would be very handy if for some reason you've got to treat this person with home health or something, again with flagell. Quinolone, which is the Cipro that you treated the outpatient with. However, if you've got a patient that you got to put in the hospital, there's no reason to put them on PO Cipro, so you're going to have to put them on IV, same bioequivalence, again with flagell. And they kind of reserve Primaxin for somebody that's immunosuppressed. All right. Expected recurrence for an uncomplicated diverticulitis is about 20 to 40%. Recurrent attacks, they say, are similar to the first, and you shouldn't expect kind of a worsening path. If they had just plain old diverticulitis the first time, that's probably what they'll have. And the immunosuppressed patient is about the only one to consider for resection after the first attack. You'll read sometimes about the young patients and being younger than 40. We used to consider those a candidate for a elective resection after the first diagnosis. I mean, that was when I was a resident, so 10 years ago. That wasn't that long ago, but now that's kind of gone away. So here's a part that we take care of, the complicated or surgical diverticulitis. And this is only about 20% of the patients that come in with diverticulitis. And the recommendations, and I'd have to talk to the colorectal guys, but they don't recommend a elective resection until the third recurrence. And kind of one of the important things, certainly for us, because we don't want to have to go back in there, is you want to evaluate the entire colon, looking for something that's proximal that you weren't aware of with whatever studies that you got to diagnose the diverticulitis. I mean, what you're really looking for is a colon cancer over on the right side. So you need to wait about 6 weeks until the inflammation is settled down, because if you try to scope an inflamed colon, chances are you're going to perforate it, so you just don't do that. And so when you take them for your elective resection, you have to resect the area that's thickened, that's grossly diseased. There may be a few diverticula in the more proximal portion of the left colon, but you don't have to get all those, just the thickened specimen. And the resection goes down into the upper rectum. Okay? You don't have to go down into the more distal rectum. So the definition of the surgical diverticulitis are kind of the stuff that we always see: abscess, free perforation, obstruction, or a fistula. Most commonly, obviously, is kind of the lower end of that is the abscess. And only 1 to 2% are going to present with a free perforation, but the mortality of that is obviously worse. Mortality of 10% for purulent diverticulitis and 40% for feculent. And the obstruction that you can see in acute diverticulitis is usually not necessarily where the diverticulitis itself is. There can kind of be an equivalent where the colon is so edematous to where there's a functional obstruction, or there can be almost a true small bowel obstruction where small bowel kind of is part of one wall of the abscess or stuck on the phlegmon, where you get a kind of a sharp kink and it's a functional obstruction. But those should get better with antibiotics, where you won't have to operate on them acutely. And late are strictures from scarring and healing of old diverticulitis. Sometimes we'll have to operate on those. These are the HINCHEY stages, and these are used to kind of describe diverticulitis. 1 and 2 are the lesser ones. Stage 1 is a small abscess within the mesentery, and kind of the definition of small versus large is about 5 centimeters. 5 centimeters should be able to be handled with just IV antibiotics. Greater than 5, you're going to have to talk to your radiologist about a drain. So that's 1 and 2. 3 is a free perforation where your abscess ruptures and there's free fluid and pus within the abdomen. And stage 4, of course, is the worst, where there is gross contamination with feces. So here's just a little picture, little CT, shows an abscess kind of up there in the right behind the left rectus with some free fluid and some bubbles in it, and then percutaneous drain to kind of handle that. So 5 centimeters is kind of the cutoff for just antibiotics versus a drain. So the emergency resection is going to be for a HINCHEY class 3 or class 4 with purulent or feculent peritonitis, and that patient's going to be sick. So of course that's not somebody you're going to do an anastomosis on. So it's a resection with an encolostomy, oversew the rectal stump, wash out any abscesses. Probably don't need to leave any sort of drains or anything like that. But you know, it's a sick patient with peritonitis, so of course you're not going to do an ostomy. HINCHEY 1 and 2, you can plan an elective resection with an anastomosis, and that's going to be 6 or 8 weeks later, and after you've surveyed the whole proximal colon. Some of the fistula things, the most common fistula is to the bladder, because everybody has a bladder, only women have vaginas, so there's going to be less of those fistulas. And so what you'll see, and this is one of those things, you know, the radiologists are looking for them if you give them an accurate history, which we're supposed to do on every CT anyway. But in talking to the radiologist, you can plan to give just oral contrast. And so any contrast that ends up in the bladder had to come from the GI tract. If you give IV contrast, that's going to be pulled out by the kidneys and show up in the urine. So over here, you don't really see the sigmoid or where the fistula is, but you've got a little rim of contrast down here and a little bubble of air. Now, if somebody's had a Foley, you can see a bubble of air, but in the proper setting where somebody gives you a history of pneumaturia, fecaluria, dysuria, recurrent UTIs, and you've got a bubble of air in the bladder and no previous instrumentation, that's a colovesical fistula. This is a solid column enema where you've got a bladder filled with contrast here, and the only contrast given to this patient was injected into the rectum and the colon, so it had to get there from the colon. This one's not quite as great. It's cut off a little bit, but this is a solid column barium enema, or I guess gastrogafrin. Don't want to give barium. You can actually see the tract really nicely, and this is the vagina. We almost never get these studies. We get the CT, but almost never the other one. So in any colon has a thickened wall, especially a short segment, you've got to consider a colon cancer. You could certainly have a colon cancer sitting there in the bed of a little nest of a diverticulum. We don't want to perform a colonoscopy acutely because there's a risk of perforation. Wait about 6 weeks. And so these are just a couple other pictures. They don't really fit anywhere, but just to show you the difference in a contrast enema of diverticulitis over here in the cancer. Even though the cancer is over here on the right, you can demonstrate it really nice where you've got normal colon here and here on either side, and you've got the apple core lesion where it's just a thin, you know, kind of a thumbprint of the tumor here and the thin column of contrast going through. But diverticulitis, you get kind of this wispy spiral where the lumen's there, but it's just kind of intruded upon by the swollen mucosa and submucosa. And this is a much longer segment. This is a very discrete. Stricture. The only reason we know that's stricture and not acute diverticulitis was the patient was kind of doing okay. This is an interval later, and they've got complaints of kind of thinner caliber stools and constipation, and there's not really active disease here. So it's, I mean, you don't have those kind of humps of the swollen mucosa, and there's this long segment of stricture. All right, it's going fast. This is another one. It's kind of hard to see. You got this big knot of bowel down here, and then there's this loop that goes here, and then this one. So I'm not sure what's going on. But when you're seeing this in real time, you'll see this puddle of contrast roll out into the abscess, and it just stays there. It doesn't follow this normal pattern of mucosa. Okay, here's one little trivia point that I found in this reading. In all my med school and all the reading I've ever done, I've never heard of Saint's triad. And they describe it as a well-known Western world affliction of cholelithiasis, diverticulosis, and hiatal hernia frequently occurring together. And that was a surprise to me. That'd probably get you a bonus point somewhere. But, I mean, I attribute that just to the frequency of CTs, where they're seeing all those at one time. And what do? They send them to a surgery clinic. He's got a hiatal hernia and gallstones. All right? That's all I have, really, for this one. Okay? Any questions? I think, no, that's it. Okay.